Right, well, welcome back, everybody. I hope you got a lunch break in the last half an hour. It's my very great pleasure to introduce Mike Dix for our next talk. I can't remember why I know you, Mike, but I've known you for a while through your art mostly. And I'm just going to read Mike's intro verbatim so it doesn't sound like I'm insulting him. The title, as you can see, is A Patient's View. And Mike's going to talk about his experiences of CLL treatment in the day unit, in lockdown and through shielding, and also in hybrid care. Mike's a versatile Brighton-based artist, cartoonist, illustrator, author and social media influencer, known for his eclectic talents and creative pursuits. And I would encourage you to look Mike up online when you get a chance as well. For over a decade, Mike has been living with chronic lymphocytic leukemia and has undergone 3 different treatments during this time. Despite the challenges, he continues to produce captivating work, including surreal architectural images of Brighton's landmarks, satirical cartoons, and charming books for both adults and children. He's very public about his blood cancer and has a few cartoons on the subject. And as he says, is there anything this man can't decide to do properly? So, Mike, handing over to you. Thank you for joining us today.
Thank you for that. I think I was feeling a lot more confident when I wrote that bio for you than I felt in the last 2 minutes. But I'm very honoured that Julia asked me to do this. And there's a trigger warning for everybody here that I am likely to get quite emotional presenting this, because to add to that bio, I've got a new diagnosis in the last 6 or 7 weeks, which I will go into with some cartoons and some jokes. But the cancer treatment is very real for me at the moment. Hybrid care and some of the problems with hybrid care are very real to me at the moment. And towards the end, I'll explain why I'm actually calling into this seminar from Madrid, from my son's apartment in Madrid. But without further ado, as they say in slide presentations, I will go into explaining a little bit about who I am, although Julia's done a great job of that. I'm an artist, cartoonist. I like to be described as a cartoonist because it takes guts to do that. And I actually thank my diagnosis of CLL for that. Before that, I worked in various jobs that I had to do lots of PowerPoints for, marketing and sales and television and internet jobs. And CLL actually made me focus a lot more on the creative side of what I do. Being diagnosed with CLL, this is the first encounter that I had with serious healthcare just over a decade ago, is for most patients, and I'm sure many of you that have relatives or even patients that have gone through this will understand that the word cancer is kind of the stopping point in the conversation that you have with your first specialist. It feels very much like it's a death sentence. You have a massive morbidity hit. It does make me emotional thinking back to that moment and looking at this picture, because it was incredibly stressful. I was 42-ish, or maybe just over. And it was a tricky time of my life to get a diagnosis, just like with anybody that gets them. It's never a good time. And I didn't fully understand anything about it. But like most patients in the last 10 years, I've become a bit of an expert in my particular form of cancer. I can even say lymphocytic, and I understand the difference between acute and chronic. And just to illustrate that, that's what we think of when we're given a diagnosis of leukemia. I make no apologies for my appeal to the small, bold children of the world. I've sat next to some of them in treatment. And their parents. But that's acute leukemia. I have chronic leukemia, which means that it's something I'll live with for all of my life, and it will be treated in various ways over that time. I know some of you have got some personal experience of relatives that have that. The first thing that comes to mind from my story, I'm going to tell some personal stories, and I'm going to try and expand that out so that it's relevant to all of you. But the treatment that is offered for chronic leukemia is called watch and wait. And I kind of think it needs another name. For me, it's fine. I'm what's called an activated patient. I quite like that title. I'd like to be called an activist patient, I think. But an activated patient, as you'll all know, is somebody that is very interested in their own diagnosis and treatment, and somebody that monitors their own bloods, in my case, and waits for the inevitable of leukemia coming back. And quite often your blood graphs indicate that that's happening before you start to feel it as a patient. I know for a lot of chronic leukemia patients, watch and wait, and a lot of other cancers that are treated in the same, given the same description of their treatment. The waiting, Carruthers, is what kills you. Many people don't like to look at their blood results. Many people try to avoid having the blood tests every 3 months in order to not see their cancer coming back. Personally, I'm the opposite way around, but I know for a lot of patients, it can be quite an interesting thing. And I think one of the themes of this talk, if anything, will be some of the language that we use. I think maybe finding a slightly better way to describe it as waiting for Godot might be better. One thing that I'll try and spin some positives into this, as I said, my diagnosis made me into an author. I got a dog to try and help me exercise called Scrabble, and Scrabble helped me write a book, which I think is one of the things that Julia first discovered of my work. And it talked very openly about my cancer and how it changed me. And it did make me become an artist, and social media made me into an author as a result of that. In fact, Scrabble is credited as the co-author of that book because, quite rightly, the book is actually about Scrabble trying to teach me to be a better human. That's the plug for the book. There won't be any other plugs, I promise you. As an activated patient, I think my first experience of clinical trials was, in fact, my first diagnosis. I was offered, I was lucky enough to be living near Oxford, and I was offered part of a research trial of a new drug called ibrutinib. And my doctor, from that perspective, because I ended up on the FLAIR trial, it was called, I ended up with one of the best hematologists in the world. And I was very glad of that. However, this image sort of indicates the mad scientist part of me that got fascinated by the science of these new drugs. One of the things about CLL that I was told right at the beginning is that it's what many hematologists certainly call the good cancer, or a good cancer. I've often questioned those doctors when they say that and said, well, if it's so good, would you like it? And they do go into slightly stunned silence at that point and don't offer to take it away from me. But what happened on the FLAIR trial was that obviously they were looking for a control group, and they were looking for people to try this new ibrutinib treatment. And I volunteered happily because it gave me a chance to get hold of this new wonder drug. CLL is one of those cancers which I think is very good for research because it looks like it's something that we can manage, certainly, and the drugs are getting better and better as we progress through that. And I was very keen to be involved in the science of this and be involved with my doctor in testing out this new drug. As it happened, I ended up, I'm a bit worried that, is my microphone working?
Yeah,
perfectly.
Excellent. It says I'm muted, but that's fine. Sorry, I thought I was just talking to myself there and waving gesticulating. I'm sure somebody would have told me. I felt like I was part of a team, and I felt like I was doing some science. The problem with that is obviously I ended up in the control group. And as you'll know, in the control group, I'm going to get whatever the gold standard treatment is. In this case, there's no blind trials, and there's certainly no placebos involved. I think I'd be very upset if there were placebos in cancer care. But I ended up getting what's called FCR, which is a form of chemotherapy used widely for CLL in the past. And I think is derived from, you can probably correct me, all the scientists in the room, but derived from research into mustard gas. And pretty poisonous treatment to have. And I ended up getting that treatment instead of the ibrutinib, the new drug. I think the biggest takeaway from that for me was that it was me that had to convince myself that I was doing science. It was me that had to convince myself that the throw of that coin to decide whether I was in the control group or getting the new drug was important for science. And it is. And I totally understand that. And if I can separate myself from my own health, I think I did a good thing. one takeaway that I would offer you is that when that happens, when you're dealing with patients, not numbers. I want you to constantly think of the patients that you're dealing with in this process, the human beings. I felt like I wasn't part of the science team because I was in that control group. I felt like more could have been done to communicate with me the science that was happening as a result of me being on that program. I felt like I could have contributed more to that process as well. And, if I'm honest, there's some tricks you could pull, like just sending me a badge every 3 months saying I'm doing science. That would be great. Or, a t-shirt or something I can wear on the bus to get myself a seat. Because I never lost my hair in this process. And so nobody ever offers me a seat when I'm leaving the hospital. I wanted to feel important and part of that team. And it was me that had to create that. It wasn't created outside of me. I wanted to be the guy with the strange hair doing the science with my doctors. And I felt like that wasn't the case. However, I want to talk about the daycare treatment that I received back in the day, 10 years ago. CLL treatment has improved dramatically over the years, and I'm very glad of you guys for doing that for us. But daycare in Brighton, where I live, used to involve going into the day ward of the hematology department in order to, in FCR's case, to have rituximab injected into me for a day on an IV drip, and sitting in a chair with nurses around me and doctors around me and other patients around me. And many people think that's kind of the worst part of chemotherapy. And to be honest with you, for me, it really wasn't. The rest of my life was going on. There were big changes going on in my life at the time. And I was focusing on a lot of other people's problems except mine. And treatment in the day unit with staff that understand your problem and patients that understand what you're going through is probably one of the best parts of the process for me. It was a day where everything was focused on me. And I was able to, it definitely wasn't like this. It wasn't like sitting on a beautiful beach and enjoying a lovely cup of tea, but it was damn close. It was like a spa day. I used to call them cancer spa days, where the whole focus was on me. And in particular, on the emotional side, Macmillan nurses in particular are very well trained to help you through the emotions of what you're going through, help you deal with the problems that you're trying to deal with outside of your cancer, and help you, in my case, kind of forget that I'd got cancer and realize that I was on a treatment path that was beneficial and working.
Mike, we've just lost view of your slides. I don't know if you're able to reshare them. So we have.
Let me just check why that might be. Sorry, let's do the technical stuff. Hang on. Sorry, is that better?
That's great, thank you.
All right, did you miss my desert island discs moment?
We did.
Hang on, let's bring that up just because it's such a lovely picture. So this is what I was describing as my spa treatment. It definitely felt like it was focused on me and enjoyable. I've got to be honest with you. I did some campaigning about getting the room decorated that we were in and getting some pictures up and stopping us having to look at each other and let us look out the window. And I know the Maggie's Centres have been campaigning on that, and I've done some work with them in the past on that because I think it should be a reasonably pleasant experience to go through this. This is my interpretation of what the day unit looks like, or looked like. It was a room with, I didn't have time to draw all the other patients, so let's just imagine them sitting in the other chairs. But it was a room full of CLL patients and full of staff looking after us. All of us immune suppressed in one way or another. We weren't, in fact, it wasn't always CLL patients, it was blood disorders in general. But all of us had to be very careful because of the treatment we were on and the illnesses that we had, to make sure that we didn't come into contact with flus and colds and children, horrible snotty children, and all of those things that patients such as me are constantly aware of. And one day I walked into the ward. We'll go back to I'm going to deal with the pandemic in a moment. So this is 1 BC, the year before COVID. So 2019, I was on an IV drip, and I walked into the day unit, and the staff all looked incredibly upset. A number of the patients looked upset. And as I looked around the room, there were beds in the room all of a sudden, and there were patients that were blatantly not hematology patients in the ward. And what had happened, and it's a story that I'm sure we hear now, and we will still hear for a while, is that the Trust's A&E department had become overrun. There weren't enough beds for all the patients, and patients from A&E were being sent up to our ward because it had space to put them in. I sat next to a guy that had broken his ankle playing football. A lovely bloke, and I chatted away to him. But to be honest with you, it terrified me that he had absolutely no idea that we were all in there protecting ourselves from common colds, because we were at the risk of dying of an infection like that. Once I'd explained to him what the risk was, he actually asked to be discharged immediately, so that he wasn't putting any of us in danger. And I sat and talked to the nurses and matron in particular about this, and they were very upset that this was being forced on them. And rather than just avoiding it and moaning and whinging, I decided that it was time to take some action. I contacted my local MPs, all of them from various different parties. I contacted CLL, Leukemia Care, the charity, and got some advice from them, some medical advice. And on the quiet, I spoke to doctors and nurses who were terrified of taking on the Trust. And I took our issue to the Trust to explain to them why it was just wrong that they were putting patients in those wards. Now, as an activated or activist patient, obviously I've got certain skills and connections that meant that I could worry the Trust by bringing MPs along, and bringing journalists into this scenario, threatening them effectively with bad publicity. And I was asked to make a presentation to the Trust board where I explained what CLL was and why we were nervous of infections, and asked them to look again at their policy of putting patients in the rooms. And I kind of predicted what their answer would be, that we don't have any room, we're trying to rebuild the hospital, times are hard. So before the meeting, I wandered around the Trust's offices and took photos of all the empty rooms in the building, including the 2 other boardrooms that they had for all their other meetings. And I put those into my presentation, and I suggested that maybe we could use those as day units, or we could put A&E patients in their boardroom. They did laugh and acquiesced in the end and banned patients. And one of the things I actually take some pride in, is that we did all of that in 2019 in December. By March 2020, we had got the Trust to turn around, putting patients into that ward. And then obviously we all know what happened in March 2020. So I like to think that by organizing and feeding back up as far as I could up the tree, we managed to save quite a few lives, in fact, during COVID. Which brings us to the dreaded C. For a lot of people, lockdowns were horrible. I need to stress that for immune suppressed patients, lockdowns were great. We love them. It meant we could avoid human beings, who largely we like to avoid while we're in treatment in particular. We didn't have to go into the hospital, which is a place that can definitely infect us. And we did suddenly get this access to treatment at home because we had to. One of the biggest problems that caused, though, was my first encounter with direct healthcare, because I'm doing chemotherapy at this time. And that was, how does a nurse, a community health nurse, come and take my blood in order to get me some more chemotherapy drugs and see how I'm doing? And that was the scariest moment of the whole process for me. And I think for Zoe, the health visitor, this was about a month into our first lockdown. And I had to negotiate with the with my healthcare team, to get this nurse to come and take my blood, because I didn't want to go outside. Then I had to negotiate with Zoe, who was given, this is an old story, but was given the way I depict her PPE is pretty much exactly what she had. She had a non-N95 mask and a plastic apron, and that was it. And we pretty much stood 2 or 3 meters apart in the corridor outside my apartment. And she rushed in, stuck a cannula in, took the bloods, and rushed back out again. And we talked in the corridor for a little bit about how scary it was for both of us. Less so for her. Very brave to be out there helping all of us. But what it led to, or one of the things that led to, was I set up a social media group called Still Shielding, because lockdowns were terrible for most people. But, you know, most of us that are immune suppressed or doing treatment, we ended up in shielding for quite a long period of time, nearly 18 months in most cases, certainly 12 months. And I set up a group for people to be able to discuss what it was like to be in shielding. And I went back, knowing I've got this talk to do, I went back to visit that group. I haven't used it much myself recently. And I was quite surprised to see that the most recent post in there is still from March this year, from somebody who I won't name, but it's an interesting post. It says, "It's been the 4th birthday stuck indoors. I don't know how to get out of this." Kind of upsets me to read this, sorry. "I know it's ridiculous, but I cannot get out of this mindset. Apart from medical appointments, I haven't been out for 4 years. Amazon is my best friend. Shopping is delivered and everything is washed and wiped twice before I can still use it. How do others manage to return to a normal life?" And that really touches me, because actually my own journey has been very similar. It became incredibly difficult to get myself out of shielding and out of that mindset, because I literally had locked myself away. The only reason that I escaped it was that my son produced a grandson, or in fact, he had nothing to do with it at all. My daughter-in-law, Rocío, produced a grandson in Madrid, and I had to fly to Madrid to come and see him. And that's when I got COVID. Luckily, 3 or 4 years into the process, and the drugs were great, and the research that everyone had done to look after me was brilliant, and I came out of it fine. But using social media has been one of the things that kept me going throughout this whole process. It gave me a community to talk to, and I think people in that community to talk to me, because I was so open about what was going on with us. And recently, just before this talk, I also asked on social media for any thoughts from people about their care. I don't want to make this just about me. There are, as you know, hundreds of thousands of patients dealing with hybrid care and home care at the moment. And I'll just give you a few of those comments, because it saved me writing anything for this slide. So here's one. I am a healthcare professional, a pharmacist, in fact, and I find it hard as a patient and a carer when HCPs ignore, dismiss, or belittle the lived experience and intuition of patients. Good health care should be based on a respectful partnership between patients and clinicians. Behaviours which diminish this relationship are not helpful. I thought that was quite a telling comment. Somebody else says that telephone consultations are the best thing for reviews, as long as you don't need to be examined. Face-to-face is much better for discussing difficult decisions about treatment. Lack of continuity of care, especially at a GP level, is a big problem. I'm not going to read all of these, but they range from people that love it and people that find it absolutely distressing. And I think the key that comes out of all of those, and from my own experience, is that there has to be this balance. And I think with both research and with treatment, you need to find the balance of making sure that you're still treating people as human beings throughout that whole process, and that they're engaged and enjoying the process rather than suffering it. I think the most telling one, and you'll see why in a moment, is a comment that I received this morning from somebody who said, "I was diagnosed 5 weeks ago, and I've had little choice but to go with what I've been told. They say to write down any questions you may have, but my surgeon gave only one option. I had no choice but to go along with their plan. That was 3 weeks ago, and now I'm at home on the mend after surgery. But my long journey ahead has only just begun. My only question to my surgeon was more of an ask, in which I said, you must bring the age of screening down for everybody." That's incredibly relevant to the next stories I'm about to tell you, but that's the kind of thing that people are reaching out on social media to say, and are not necessarily feeling heard, I think, by the health professionals. A couple of other takeaways from lockdown and shielding for me. Julia will probably testify to the fact I posted an awful lot of selfies during that time. I perfected the art of taking multiple pictures of myself and developing multiple personality disorder, I think, throughout that whole process. One of the personalities that I definitely developed and have since lost since I left lockdown was what I call Whiskey Mike. I developed, like a lot of us, a very unhealthy relationship with alcohol during COVID. And I decided 2 years ago to completely break that. I no longer hang out with Whiskey Mike. In terms of how that affected healthcare, I did go to see my GP because I thought that some of the health problems I was getting were connected with my drinking. And I said that I really needed some help to give up drinking. And my GP patted his stomach and said, well, if you find the answer to that one, let me know, which was entirely the wrong thing to say. Actually, probably the right thing to say, because I said to him, well, I will go and find the bloody answer and I'll come back and tell you what it was. And I have subsequently been in to tell him that it's willpower that does it. But for a lot of people, that's another problem, that drinking away their problems was something that COVID generated. And I'm not sure how you'd spot that with remote and hybrid care. A couple of other examples of where I ran into research. Didn't have a lot to do during lockdown, so I volunteered to be on any trial that was relevant or interesting to me. Again, activated patient status. One of them was, in fact, for smokers over the age of 50. And it's a trial, I can't remember who ran it, but it was a private company running it for the NHS, looking at people that had smoked for over 20 years and that were over the age of 50, and providing regular CT scans to look for lung disease developing. And I did that for 2 or 3 months. It was quite strange because the CT scanner was in a lorry parked in Asda's car park, which moved around Brighton. So I had to find these strange locations in the middle of winter to go and get my scans. And there was a part of me that thought it might be a euthanasia program for the over 50s, because I saw people going into the lorry, but I never saw them leave. Turns out there was an entrance at the back. But I was quite happy to take part in this. I did 2 scans. On the 3rd scan, I was sent a letter saying that I needed to go and see a lung cancer doctor. And as somebody that had smoked for 40 years, and I know I shouldn't do, I totally understand all the medicine or all of that. I have subsequently packed up, but I thought, oh, great, I've got another cancer diagnosis. That's just what I need. And 2 weeks later, it did take 2 weeks, and that did unnerve me. And you know, I did look at the internet, and I'll talk about that in a moment. But obviously, I looked at the implications of lung cancer, and I turn up for an appointment with a lung cancer doctor who opens up my file as I walk in the door, as they do, and looks at my scan and says, oh, well, what we've found here is a lot of activity in your lymph nodes in your neck. And we're a bit concerned that may be an indication that you've got cancer, lung cancer on its way. So what I'd like to do is do a biopsy. And I stood and looked at her and I said, okay, well, can you just check the rest of my record for a moment? And she looked at the rest of my record and went, oh, you've got chronic lymphocytic cancer. And leukemia. And I said, yeah, and that's in my lymph system, isn't it? And she said, yeah. And I said, and I'm currently halfway through treatment. So you would expect my lymph system to be full of useless white blood cells, wouldn't you? And she said, yeah. And I said, and do you always offer a biopsy in this situation? And she said, yes. And I said, well, okay, I've had 8 years of this leukemia and I've never been offered for anyone to hack up my lymph system. And she apologized, and we talked about the lack of intercommunication between departments. And I think in this case, and I didn't really dig that deeply because I wanted to forget it straight afterwards, but in this case, I think it's something to do with the way the research program was set up and how it informed the NHS of its results. Because my hematology doctor couldn't access those scans, or consultant, sorry, couldn't access those scans, whereas they were forwarded to the lung cancer specialist team by the research program, as I understand it. I could be wrong. And if anyone here was working on that program, you might be able to enlighten me as to what happened there. But obviously it's something that from a patient's point, I can understand from an NHS point of view, from a research point of view, why that's just a little glitch in the admin of the system. But from a patient's point of view, that was almost devastating. The little picture of me is because another trial, not a trial, but a program. In fact, let me explain that. For the 4th scan in that trial, I missed an appointment. I went to the wrong Asda car park, and I had to go to my GP to rearrange this appointment. And the receptionist at the GP's managed to, instead of rearranging that appointment, managed to book me in for an ADHD test. And I've no idea what it was about my behavior in reception that made her think that, but turns out it was just an admin error again. But I then got pestered by text messages and emails to complete a questionnaire about ADHD, which, without having much to do, I decided to do, and then discovered that I'd actually got ADHD and had probably been living with it for all of my life. And I know how difficult it is to get a diagnosis of that, but I got a random diagnosis of it, and it did explain an awful lot to me. One of the first things I did was ring both of my ex-wives and tell them that, and it did make things very clear for them about how my brain works. And the reason it's a toddler there is that it is a toddler brain disease that I have. So there's my lung cancer doctor telling me that I've got a problem. One of the good things, let's go back to the good things about hybrid care, is that I love getting blood results. I live in Brighton. I live about a mile away from the hospital. I can book a phlebotomy appointment to get my blood tested now. I can walk into phlebotomy, have a chat with a phlebotomist. I love the fact that I can say that word over and over again. I didn't even know what it meant 10 years ago. And tell them which vein is the best vein to take my blood from, and then leave and walk along the seafront back to my house. And by the time I get to my favorite coffee shop near the pier, I can open up an app with Patients Know Best on it through the NHS app, and I can see my own blood results. And I can see 20 or 30 indicators in my blood, including my white blood cell levels, lymphocytes, and I can monitor my own blood before my hematologist has even looked at them. And I can tell how well I'm doing under treatment, or whether my leukemia is coming back. I absolutely love that. I'd like it to happen more often. I'd like more regular tests. I'd like to be able to test whenever I want. And I'd like the app to be updated. And if I could put in a plea for somebody to do some smart research, I'd absolutely love something like a diabetes pin in my arm that just constantly monitors those blood levels and tells an app so that I can create beautiful graphs to explain where my health is at any given time. Probably save an awful lot of time of phlebotomists and hematologists in the process. Very quick personal note. About 9-10 weeks ago, I was very lucky to meet a new lady in my life. This is Jane. And first date in Brighton was absolutely lovely. And the second date in Brighton was spent waiting for a colonoscopy. Because and this is where we're going to get brutal. I thought I'd got piles, and with a new, let's not go into too many details, but with a new romantic interest in my life, I thought that was something I should probably sort out. And I contacted my GP and remotely was told that it was probably piles, but if I wanted an examination, I could be referred to the colonoscopy department. I thought that was probably a waste of a cancer doctor's time. Very much like the lung cancer doctor that I'd seen erroneously. But I went along for it, and for the first time in Brighton, a man, in fact 2 men, had access to my bottom. And they immediately noticed a tumour, which, in fact, just in terms of research, I love the fact that there was a trainee in the room, and my doctor asked me if I minded him having a feel, because it would be good for him to identify stage 2 tumours with his hand, which I said, yeah, knock yourself out. But maybe there was a better way to tell me I'd got a stage 2 tumour than that. It was quite a dark day. But then we ended up sitting in front of a surgeon about 6 weeks ago. I'm losing track of time, in fact, and was told that I had rectal cancer. I'd seen it, in fact, on the colonoscopy myself. It's an ugly little bugger. I did call it Donald Trump for a while, but now I've realized we can't get rid of Donald Trump. So I'm now calling it Liz Truss, because I think at least there's a chance that malignancy can go. Sorry for the politics. Yeah, so Liz Truss was discovered, and the surgeon presented very much like the quote I gave you from the anonymous person that replied to my post. The surgeon pretty much gave me one option. He told me that there had been a multidisciplinary team meeting. There's a word I can't say. And that there'd been a discussion, but the outcome was that I was going to have 5 days of radiotherapy followed by having my anus removed. and he was as clear as that. He told me I'd be having a stoma. My new girlfriend was in the room for that conversation. I'm just glad that I'd done some research before this meeting, and I told her that there was a 20% chance that I was going to end up with a stoma at the end of this meeting. And it turns out that that's exactly what the doctor was offering me. He did, however, indicate in his dialogue with me that that there was some discussion in the MDT and that there had been a difference of opinion about the best treatment. And I asked at that point, well, can I talk to the other consultant that proposed a different treatment? And he actually encouraged me to do that, which was very refreshing. I didn't feel like I was only being offered one option at that point, that there was another option. And that's when I met Dr. Gilbert, my second doctor. So I probably shouldn't name these doctors for personal reasons, but let's call him Dr. L and Dr. G, even though you've now got a name. These are the two doctors. I do have a theory about surgeons. You may correct me if I'm wrong, but surgeons are brilliant at what they do, and geniuses with very little bedside manner in most cases. I'm generalizing, but the ones that I've met don't tend to have a particularly emphatic approach to this. And they're very good at what they do, and they want to do that. They do think that surgery, in this case, there's a 70% chance that he can get rid of my cancer, and there's a 100% chance that he'll get rid of my anus by doing this, and that I'll have a stoma. But the other doctor, Dr. G, talked to me about something that's been researched. It's quite an old procedure, but it's actually been recently re-looked at, re-examined as a treatment for exactly my form of tumor. I call it the nuclear butt plug. I think its official title is Papillon. And it's a combination of chemotherapy, radiotherapy, and then highly targeted radiotherapy, which is the nuclear butt plug option. I have weighed up both of these treatments, and I have done as much research as I can. Now, one of the things that we're often told as patients is don't look it up, don't Google it. And I totally understand why we shouldn't Google it. Primarily, I don't imagine you can see what's on these screens. It's a combination of my blood results, some research papers into the form of cancer that I've got and the various treatments. And also in the top left there, the top Google results, which are wonder berries that I can eat to avoid having cancer. Now, my argument is I'm an activated patient. I can go look for research papers. I can look for doctors presenting their own stories. And I can try and understand the data and the figures as much as I can, and then ask relevant questions of my specialists. But, there's a huge amount of terrible information out there about cancer. What I would put forward to you all is that as researchers, you need to find a way to make compelling narratives out of your research for patients just as much as for health professionals. One of the disturbing things about watching doctors, American doctors in particular, present their findings is when they start talking about how they can protect your billings through this process, because they feel that they're only talking to doctors. And if they were only talking to doctors, they shouldn't put their videos on YouTube. They should find another way to communicate to patients. But the compelling stories are the gojo berries and the, go to Tasmania and have a healing doctor wave crystals over you. And whenever I talk about my cancer online, I can guarantee you that I am bothered by people who want to tell me how my diet can change to get rid of my cancer, and also how if I discovered faith, it would help me as well, despite me telling people I really don't need that kind of information. But I did the research in this case, did my own research. And I decided that the nuclear butt plug was the best option, and I start my treatment on the 30th of December. And that's because of waiting lists more than anything else. I'm at a stage 2 tumor, and I really should be having this treatment immediately. But we can't. We're doing it at the end of December. And I looked my doctor in the eyes, and I asked him if it was okay for me to visit my grandson. Because because I find it very difficult thinking about my grandson and my cancer in the same brain space as you've just seen. And he told me that if he could write a prescription for me to come to Madrid and hang out with Lucas, who's 2 and gorgeous and adorable and Spanglish and fun, then he would do that. So I flew out this weekend to come and see him after seeing my doctor last week. And that's the kind of medicine that you should be providing for us, because I've spent the last 2 days joyously hanging out with him. And being honest with you, you're dragging me away from him. So as soon as this is over, I'm going down the park to hang out with him. The point of that really is that we need to get control of our own healthcare as patients. I don't want to be a victim to deadlines and timelines. It's been terrible for the last 6 weeks, not knowing when my treatment would start and what it would be and how it would affect me. Because I cannot make plans either for my new female partner or to see Lucas, which is the most important thing in the world to me. And I just want to be able to make those plans and feel that I've got some control over the situation. And I want to do the science. I'm really interested in this Papillon treatment in particular. So what that might mean is that I might lose this wonderful head of hair, which means that it's lucky I secured a girlfriend before that happened. And I will have a nuclear butt for a while, but I don't think I'm going to get a particular superpower out of that. I've read the research and only Marvel Comics tell me that that's going to happen. But I'm preparing myself with cartoons just in case. A couple of other flippant points really is this isn't anything to do with you. This is mainly about cancer charities, but bear this in mind because I've had similar advice from medical professionals. I've never run a marathon in my life. I don't want to run marathons. I admire people that do. I think they're mad, but I really do admire people that run. My younger brother is in fact an ultra marathon runner. He runs up and down mountains in all of his spare time. But I am often told by cancer charities and by health professionals that I could take up running, raise some money for cancer. And I really don't want to do that. I'm a grumpy cartoonist. So if any of you want to recommend that your patients talk to a grumpy cartoonist about their cancer, then get them to call me. That's fine. But please stop telling us that we need to become ultra fit marathon runners and wear lycra or start cycling. And the reason I say that is it's about the language that we use to describe cancers. And the way that we're expected to behave as patients. We're always treated as brave. We're always treated as courageous. We're always told that we can fight this. I don't believe you can fight cancer. I believe that it's a very unfair fight. And I think if you're being told that you're failing at fighting cancer, that's going to make you feel mentally much worse from a mental health perspective. And I think if you're being told that you should be a marathon runner and you should be like these amazing people that go and do this stuff despite cancer, and you don't want to do that, and you end up feeling even worse about your cancer. So you've got to find the individual ways that make people feel good about their cancer. In my case, it's the science and talking about it and narrating my story to help other people spot their own cancers. That's what I want out of this, and advocacy for others, as well as myself. And I think that's just as good as running a marathon, to be honest with you. So, in all due deference to Macmillan trying to make me do that, please stop. I don't want to run a marathon. And then finally, just to dwell on the fact, I'm not allowed to share pictures of him because my son and daughter-in-law refused to let me share pictures of my grandson for various good reasons. But this is me and Lucas today jumping in puddles along the riverside of Madrid, preparing for this presentation. And as I say, now that I feel like I've probably got to the end of it and can ask for some questions, I will be heading back there as soon as I can. Please ask any questions you've got. That's my presentation done.
Mike, thank you so much for giving up time for us today. We really appreciate it. The chat is full of lots of thank yous there, and I think you've probably given everybody an awful lot to think about as well, which is really useful. I have a couple of questions in the chat other than all of the praise and thanks. So if I can just quickly pass those on to you. The first comes from Sanella, who asks, as a patient and a creative professional, how do you think storytelling can be used to improve communication and engagement in healthcare for both patients and professionals? And she adds, including Scrabble, of course.
Yeah. Well, Scrabble's had cancer as well, and I helped her through that process. She had skin cancer. And it is in a new book I'm working on with her, at the moment. She was very stoic and she did like running. So, she's a good candidate. I think it's really important for me. The comments that I get when I talk about it, the picture of the colonoscopy, which I titled, I'm ready for my close up, I shared. And a lot of people started talking to me about that. I think one thing I didn't do in the presentation was talk about the language problem that I'm now encountering with a secondary cancer, in my anus, is that, the words that we have to describe a situation that somebody with cancer is in are not very good when it's colon cancer or anal cancer, because the number of people that write directly to me and say, God, Mike, that's shit, or bugger, what a terrible thing. And you go, yeah, it's inappropriate language in this situation. We don't have a way of describing, anal cancer and colon cancer in a good way. And I think we should find that. And, as a comic presenter and cartoonist, I think there's nothing better than poo and fart gags. I'm enjoying those with Lucas at the moment. Apparently his mum has the smelliest farts. And that's, at that age, we can deal with poo and farts and everything else. And when we get to adults, nobody wants to talk about it. So I'm hoisted by my own petard of talking openly about my good cancer. And I did go through a week of dilemma as to whether I talk about this one. And I think it's really important that I do, purely because if I just get one or two people to go and get what they think is piles checked out earlier than I did, then that's going to achieve something, isn't it? Basically, we're going to get somebody treated a bit quicker, and that's important. Just to make a really politically contentious thing, and I am told often not to mention this, but I am absolutely certain that I share a cancer with at least one member of the royal family. And I do wish that that particular member of the royal family would come out and admit which cancer they've got. I won't go any further than that, but I think it could do a lot more good if people like that were talking openly about the problems of your bowels.
Absolutely. Mike, I think all of the rest of the messages in here, I'd encourage you to have a look at them before you disappear off down the park, are words of thanks. And I think it's always nice for people to have opportunity to thank you, given that we don't have you in the room. Obviously,
Julian, have you seen the questions in the Q&A part as well? There are some questions there.
I have only seen one question, sorry.
Q&A, there's 4 questions for Mike.
Oh, apologies.
Who's your favourite Marvel or DC superhero, if you have one?
We have to know that, sorry.
Oh, that's tricky. It's the Incredible Hulk. It's about anger management. Macmillan are very good at, they actually offer free counselling with a Bupa scheme. If anybody needs to recommend it, make sure you do, because it's a little hard to find on the Macmillan website. But they can offer you 4 or 5 sessions. And I actually booked some for this diagnosis because, I have a public mask, presentation of myself, which is the funny, creative, artistic guy. And I have one for my family and friends. And then I'm struggling to talk about the guy that's really deep inside me, which is really upset about this. And I took the first session I had with the counselor. I was trying to work out why I get so upset about thinking about Lucas and the future and my, hanging out with my grandson and driving him mad with weird books and cartoons I do about him. And it turns out there's some anger in there that I'm not really dealing with. And the anger I'm feeling is one thing I just will not do publicly, which is to say that it's not fair, because, it's random. I've been hit by a cosmic ray that has affected my DNA in one way or another. We don't know why you get either of the cancers I've got. I can't tell you how irritating it is that I gave up alcohol 2 years ago and I gave up smoking 3 months ago. And neither of those things are given as the cause of either of my cancers. And that's quite annoying in a lot of ways. So there's anger, and, the Hulk with his being affected by radiation and allowing that anger out to do good sometimes. I think that's probably my favorite character. So yeah, don't get me on the Marvel. We'll be here all afternoon. And shall I read through these other ones and try and give you quick answers? Is that?
Yeah, please.
From your perspective in social circles or everyday life in general, who has been the most helpful for you to hear about or talk about? so I treat social media as a publishing medium. I've got enough of an ego to think that I don't read it as much as I write it. So I feel that sharing my story is really important. The people that really touch me about it are the people that respond to those posts and those jokes and those stories with their own stories, and how relevant they are. So I lean on those. I lean on friends that I know have gone through this, that have similar attitudes to me and similar thoughts to me about it. But primarily, I want access to my doctors and researchers. I can't stress enough that I want good science. When anyone wishes me good luck in this process, I always ask for good science rather than good luck. Because there's nothing lucky about any of this. And, finding the right doctors, finding doctors you can trust, and finding doctors that will communicate with you about it. The Papillon treatment, for example, my doctor, Dr. Gilbert in Brighton, I am happy to name him. He did stick his neck out in the MDT meeting. I was pleased that the surgeon allowed me to talk to him, or encouraged me to talk to him. And then when I did, I found him a partner in this process. I really did find him an engaging guy that was interested in my interest in the science. And we sat there and went through the numbers and the scans and the research that I'd done. The French scientist that is doing some great work on Papillon. And then he got me a conversation with the researchers in Guildford that are pioneering this treatment now and improving it all the time. And I didn't need to talk to them from a medical perspective, but it was really good to talk to them from an engaged patient perspective. So I know who's recommending this. So it is scientists more than anyone else. Other people's health stories I absolutely appreciate and admire. But being honest with you, I'm not the kind of person that normally joins a group of patients, because I don't like to see myself as a patient. I like to see myself as somebody in this process of engaging with the medicine and the science. It's different for lots of other people. Some other people want much more than that. But also then the other thing I would stress is that I don't trust my doctors. I really do want to look them in the eye. With both of these doctors, I have looked them in the eye and asked them if they're any good at their job. The ones that can't make eye contact then when they give you the answer are the ones I'd rather not be under the knife for, to be honest with you. So the next question, which healthcare professional approached you to take part in the clinical trial? Do you have any advice how we should approach patients about trials? I totally think we need to find a way to get more patients engaged in trials. For me, I was in Buckinghamshire when I was diagnosed, and the hematologist I first saw in I can't remember which hospital, Slough, I think, hospital, I said to them, how quickly will treatment start? And she said, it depends on whether you've got private healthcare or not, which I thought was the wrong answer from an NHS doctor, but probably the right answer in Buckinghamshire or Windsor. To which I said, well, is there any way that I can get better drugs, the drugs that I might get on Bupa, if I don't pay for private healthcare? And she recommended a trial. So it was an honest conversation about what motivates individuals. I find personally working out the motivations of your own doctor. If your own doctor has done some research or contributed to research or presented their findings, then find their PowerPoint and quote it back to them and ask them questions about it. It's important that you know their understanding. And in this case, trials came up very quickly in that conversation. And as I say, the real irony is I've brought a prop. These are my current chemotherapy tablets for my CLL, not for my anus cancer. And it's acalabrutinib. So 10 years after going on that trial, I'm now on ibrutinib, which is the wonder drug that I was hoping to get 10 years ago. So that, there was a 50-50 chance that I would have been on ibrutinib 10 years ago. And as it turns out, it's a good treatment. However, I did go back and read the research, and in the first trials of ibrutinib in Australia, out of 40 patients, 7 died because they gave them far too high a dose in the first stages, basically, and they had kidney failure, which then led to better treatments. So contributing to science is great as long as you're not one of those 5 people, I think, sometimes. There's a couple more here. Have we got time, Julia? I'm in your hands.
You're on mute, Julia.
I am on mute, yeah. Just one last question then, which was from Lisa Slade, asking whether or not do you think it would have been helpful if you could have been in that MDT meeting, and
yes,
would it give you better transparency?
Yes. Now, I don't know how you determine which patients should be allowed in there and which would need an advocate. And I think this is something that, I knew I'd only got a short period of time here, and there's a lot of stories I could tell you. Most recently, there's two things that I haven't really covered, so I'll cover them very quickly. The MDT meeting, I think the only voice in that room that was mine was a Macmillan nurse I'd never met. Now, I've had a Macmillan nurse for 10 years, the latest one for 4 years, and she does know me reasonably well. If she'd been in there from hematology, she would have understood my attitude to treatments, etc. But there was nobody in that room that had spent more than 5 minutes with me as they were determining the outcome of this surgery. And I personally think I'd have been able to contribute in that meeting and listen to the science and not be particularly emotive about it. I do know other patients that would not want that at all and would not want that level of discussion about their healthcare. I know patients that regard their doctors as some form of gods, and what they say is right. And the outcome of that meeting, that guy's quote of, "I was offered no options," and I'm really worried on his behalf that he could have had other options to consider. And the things that you take into account after, when you're faced with, patient choice, which is, again, a language I'm not entirely sure we should have. Every patient I talk to about patient's choice just says, why the fuck are they asking me? They're doctors. Basically, why am I the one that's making the decision? Excuse my language. And I agree with them. But I do want to be able to put my 2 penny in. And in this case, I've had cancer for 10 years. I think I've done all right out of that. And I know that with CLL, I might have it for another 20 years with the treatments as they're going, but I will always have it. And when I had a meeting with a surgeon telling me that I'd got a cancer that was operable and was at stage 2, I didn't need the Macmillan nurse in the room to hold my hand and talk about the emotions of it, although you can see that I'm emotional about this process, because the cancer conversation I'd had 10 years ago. In this case, I wanted to get straight down to science, and I would have welcomed being invited to that meeting. I think after those initial meetings, if the Macmillan nurses in particular were able to spend some time with patients and assess their activeness and engagedness, and then get them in the room of an MDT meeting or find them an advocate, I think that would be very powerful. A lot of the stories that I've picked up on social media that I haven't read to you are about people that advocated well for themselves within the NHS. I personally think that as a white middle class, good talker, I have an advantage in that I shouldn't have. I think there are patients that absolutely need me sitting next to them sometimes to advocate on their behalf, because I understand the pressures and the system, and I'm not angry about it. I just want to make it work for every single patient. So yeah, I think MDT is really important. And then the other one is just about communication. I now have 2 sets of consultants and 2 sets of Macmillan nurses and 2 sets of treatment to worry about. I have 5 apps that I have to navigate in order to pull all that information together. I have 2 departments 500 yards apart who use 2 different systems to arrange appointments. And very quickly, I can tell you that in the last 2 weeks, what happened was that as a result of the MDT, the surgeon recommended surgery. I then go off and research with Dr. Gilbert this other treatment. He puts me on fast forward to get through into that treatment as quickly as possible. Because they make their appointments by phone, I get a phone call from my surgeon's diary manager to say, you're going to be booked in for surgery on the 5th of December. And I get a phone call 2 hours later from my radiotherapist's diary manager saying, we're going to book you in for radiotherapy on December the 30th. Now, if I was a patient that didn't know what was going on in this process, I would have turned up for surgery on the 5th, and then they would have tried to put a nuclear butt plug in my Barbie bum, as they call it, because it would have been sewn up. And I think that might have been a bit of a shock for them at that day. So I'll leave you with that, because it's good that they didn't put me on before lunch, I think.
Thanks, Mike. And I think you're a good candidate for filling in the questionnaires on where the NHS needs to go next.
I did spend some time telling Wes what he should do, basically. Yeah.
Thank you ever so much for your time. We have run over, but I think it was just incredibly important to get everything that you had to offer.
Yeah, I'm not allowed. I know I'm not allowed to talk because I'm only doing the organisation. But can I have just one quick word, please?
Mm.
Yeah. Mike, that was phenomenal. And I'm going to talk on behalf of everybody who's online watching. Fantastic. I really think that the whole approach of cartoonizing, characterizing, making life more appealing like that will make life so much easier for patients. I've sent you a link to something called Little Journey, which happens to be about for kids, but I think for everybody, it makes such a difference. And I think bringing the graphic design and cartoon world and the really serious clinical trial world together is just a phenomenal thing.
I can't deny that if I do slightly think about why I put so much effort into this for you guys, basically was, look, I'm available for hire as well and need the work. So,
but I think it's a brilliant thing and I think everyone should think about that, because sometimes when things are so serious, sometimes you've just got to laugh. Because if you don't
is funny, you know, when I was first told that I was having a Barbie bum operation, that was by a patient, not by a doctor. And I've now informed all of my doctors that that's what patients call it, basically, because I think that's hilarious. And I think if we got to find the humor in this rather than the gloom. You don't want to make patients feel worse, and you don't want to make it harder for doctors to explain things either. But the research side, I absolutely think, find a better way to tell this online, because you are competing with morons who are, you know, it's a very easy narrative they've got. It's a very easy solution they're offering, and it doesn't bloody work. And I spend as much of my time not arguing with those people, but finding ways to communicate that you should be looking for a better way to get your answers, basically, than from somebody offering you a solution that is just unreal, you know.
Yeah, I agree. Anyway, thank you. Sorry, apologies.
Right. I'll pull it back onto time, but I would just like to say, very, very good science, not good luck with your new treatment. And thank you very, very much for your time this afternoon. And enjoy Spain. I'm in Spain as well at the moment, so I know how beautiful it is outside. Go outside and have a wonderful time with your grandson. And we wish you very, very best good science.
Thank you, guys. I really enjoyed doing this. Thank you.
Thank you.